Okay, so we will not ask you in detail. Usually we don't ask the veno for preparation ke apa ke, we will not ask, but it's good to know. Okay, and this blood transfusion, then this melanie important. Okay, usually I ask 1 unit of white red cell. So what's your expectation? Okay, her hemoglobin to be increased like 1 gram per deciliter. Okay, so for example, patient has hemoglobin 6 gram per deciliter. You want to bring to 8 gram per deciliter. So how many unit you want to give? Macam tu lah. Okay. So the beta thalassemia, pre-pregnancy, we will not ask you in detail, just to know je. But bear in mind, genetic counseling jangan lupa. That is a very common, the student suka hati je. Okay, patient has thalassemia, you don't ask about the patient punya husband punya thalassemia status. You don't ask about the previous child punya screening too. Okay, you must ask. Okay, because how could you know that this the fetus she is carrying now has the increased risk ataupun just mild carrier? How could you know? So you have to ask. Okay, so genetic history. Okay, and apart from asking about the husband and previous child, you need to ask the sibling and parents as well. Okay, her parents is thalassemia disease carrier, any sibling diagnosed with the thalassemia carrier or thalassemia disease. Okay, review of medication, we will not ask you in detail, don't worry. Okay, this one you have to know. Okay, so supplement folic acid, continue aspirin, low molecular weight heparin. Okay, if especially if the patient is planetamized. But when I was a medical student, we have a lot of patients who has planetamized. But in your day, with the advances in our treatment modality, patient does not macam tak progress sampai tahap yang splenomegaly ke apa ke, tak ada lah. Okay, so patient still have the spleen, so no need for this aspirin ke loma, usually no need. Okay, and then you have to screen for the complication. Hypothyroidism, you treat accordingly lah. Patient is diabetic ataupun GDM, you need to treat accordingly lah. Okay, so this one you have to know. Want to transfuse in the thalassemia patient, aim hemoglobin level more than 8 gram per deciliter. If it is less than 8 gram per deciliter, you need to transfuse. Okay. Thalassemia patient, okay, mode of delivery depends on the obstetric indication. Okay. Kalau thalassemia tapi fetus is appropriate for gestational age, okay, and then tak ada apa-apa complication, she can deliver vaginally, no problem. Okay, thalassemia is not an indication for cesarean delivery. Time of delivery depends on the patient condition. If the thalassemia is well controlled, well optimized, you can allow post-day. Tapi patient has a thalassemia plus GDM or metformin. Patient has thalassemia plus IUGR, so you need to deliver early. Okay, so postpartum also sama je. Okay, but at least satu ayat ni kena keluarlah long term follow up under hematologist. Okay, bukan ONG je pandai-pandai management lah. Thalassemia you have to offer joint care with the hematologist. Any questions?
Doctor, I have a question.
Yes.
Since parenteral iron is contraindicated in the first trimester, so if oral therapy is inadequate in first trimester, do we proceed with blood transfusion or we increase the dose of oral?
Okay, actually we are scared to use the iron in first trimesters, but scientists, they have done research in the rat embryo. Okay, rat embryo, and then they see they found the iron is release the superoxide. Okay, superoxide, and then which cause the oxidative injury to the developing embryo. So the iron is embryotoxic, especially in early gestation. Okay, so previously we don't have knowledge kan, so kalau kita tak tahu wanita tu dah mengandung terus, kita start iron supplementation. Actually, you should not start iron supplementation until 8 weeks gestation. Okay, better you wait until 10 week gestation if her hemoglobin is normal lah. Okay, kalau hemoglobin normal, no need to start until 8 week gestation. After 8 week gestation, then you start the iron oral iron supplementation, no problem. Okay, oral iron. Kalau parenteral, kita lagi takut because parenteral, we are injecting directly into the venous system or we are injecting intramuscularly. Okay, so there will be increased concentration in the body. So we are afraid that this iron will be harming the developing embryo. That's why we don't use the parenteral iron, especially in the first trimester. So kalau first trimester, patient to anemic, some patient we just give the oral iron je. We don't give parenteral. Tapi tak pernah jumpa pun patient tu sampai anemia hemoglobin level 2 ke 3 ke, macam tak pernah jumpa lah in first trimester tu.
Okay, understood.
Physiological changes I didn't include in my slide, but usually MCQ boleh keluar. Thyroid, the physiological changes, MCQ je, okay? And then the history, physical examination, investigation too. If you get hypothyroidism in pregnancy for your modified longase, you need to know lah. Okay, so causes of hypothyroidism in pregnancy, grave disease, gestational thyrotoxicosis. Gestational thyrotoxicosis itu sekejap je. After delivery, it will become normal. Okay, so usually we just monitor the thyroid function test only. Okay, when it resolves spontaneously, no need to give any treatment. So history taking, let's say patient say, oh, I have been diagnosed with a grave disease even before the pregnancy. So what you have to ask is, okay, how old is she when it was diagnosed? What is the clinical presentation at that time? What medication has been started? Okay, what treatment history, whether she require medical treatment ke, surgical treatment ke, ataupun radioiodine treatment ke, okay? And then there any complication, any history or admission for the thyroid storm ke, okay? Kena tanya. And then currently she is on any medication or not, and then you have to ask, does she have any follow-up with the endocrinologist or obstetrician before embarking this pregnancy? Okay, macam tu, you kena tanya semua tu. Okay, and then now let's say depending on the let's say you are seeing the patient in the first trimester, so how is the symptom now? Okay, so symptom improving ke ataupun tak asymptomatic ke, ataupun symptom tu persistent tapi not worsening, macam tu. So you kena tanya. Okay, and then you have to ask, do you remember any investigation taken in the pregnancy? First trimester reading berapa, second trimester reading berapa, third trimester reading berapa? And then the any changes in the medication? Okay, that she's taken sometime. Patient, they have to stop the medication because her symptom improve and everything. So endocrinologist advise her to stop the medication. She stopped medication and continue her pregnancy without any complication. Sometimes patient tu initially tak payah anti-thyroid pun. And then tiba-tiba during the pregnancy, she required the anti-thyroid. Okay, so you kena tanya what is the reason for flare up of the symptoms apa macam tu lah. Okay. Hypothyroid pun simple juga. Hypothyroid you have to ask what would be the cause, okay, autoimmune ke, post-surgery ke, post-radiation treatment ke, ataupun overdosage of the medicine, anti-thyroid treatment. So you can tanya, and then what is the current thyroxine supplementation, whether it is dose is adequate or not, okay, and then whether she has any signs and symptoms of hypothyroidism during this pregnancy or not, macam tu lah, okay. So kalau patient tu ada neck gland goiter, so you have to ask the airway compression punya symptom lah. Kalau tak ada obvious goiter ke apa ke, tak payah tanya lah, okay. Tapi but in Malaysia, most of the women they are wearing hijab kan. Kalau you tak nampak tu, you just for the sake of completeness, just tanya je yang compression symptom tu. Okay. Constitutional symptom, for the sake of completeness of the history taking, you have to ask. But in reality, clinical practice, I have not seen patient hyperthyroidism, thyroid cancer in pregnancy. Mungkin ada jugalah, tapi very rare. Kalau kes-kes macam tu ada pun, we will not put in the undergraduate exam, so don't worry. But you still need to ask the constitutional symptom tu, okay? So another thing, remember, yang ni ONG posting je. So I will focus on the abdomen only, not like that. Okay, sometimes I've got a patient, hyperthyroidism patient. Okay, she's 28 weeks pregnant, modified long case. So I asked the candidate to examine the thyroid. I didn't ask the candidate to examine the abdomen because her main problem is thyroid. Her abdominal assessment, everything is normal. Okay, so I want to see whether the candidate can elicit the positive clinical finding correctly or not. Okay, so it does not mean that ONG posted I have to check the abdomen only, no need to see other things. Bukan macam tu. Okay, patient with heart disease, I will ask you to do the cardiac examinations. Okay, how do you check pulse rate? What is the character of the pulse rate? Okay, so rhythm macam mana? How do you check the JVP? So I will ask, not just the abdomen only, because you are the MBBS student. Okay, so MBBS maksudnya you need to know everything in general, and you must be able to identify the major problem. Okay, tak kisah ONG ke ataupun like surgery ke, sometimes okay, patient may have acute gastritis in pregnancy. Itu pun ada juga lah. So I will ask you about management of the acute gastritis, okay, rather than induction or the induction of liver ke, time of delivery ke. The discussion must be relevant on the patient problem lah, okay. So yang ni, I think medicine you dah already learn in detail, sama je. Okay, semua sama dengan medicine. Okay, ONG ni nak tambah sikit je. Okay, sometimes, especially if the patient is the autoimmune disease, macam Graves' disease. Graves' disease has the thyroid stimulating and autoantibody. This autoantibody will cross the placenta. When it crosses the placenta, it reaches to the fetus, and then it will go and stimulate the fetal thyroid gland. So when it stimulates the fetal thyroid gland, the thyroid will increase in size. So increase in size, fetus will have goiter. When the fetus has goiter, fetus too cannot maintain the head in flexion position. So the fetal neck will slowly extend sampai fetus may have the malpresentation, face presentation ke, okay, boleh jadi juga because of the goiter, okay. Or sometimes that enlarged thyroid gland will be compressing on the trachea and esophagus, especially the esophagus. Okay, so the fetus cannot swallow. When the fetus cannot swallow, the fetus, they will have the polyhydramnios. Okay, and then sometimes fetus will have the increased thyroid hormone in the fetal body. So when there is an increased thyroid hormone in the fetal body, fetal will have tachycardia. So that tachycardia, when you do the CTG, you will see the increased baseline fetal heart rate. Or when you see the ultrasound, also you can see the heart rate tinggi. Okay, so that's just a little bit, yeah, you need to remember. Okay, yang lain semua sama as a management of the in the medicine. And then, and for undergrad, we will not ask you how do you manage thyroid storm in labor. No, not like that. Okay, so we will just ask you simple lah, yeah, basic principles. No need to get scared. Okay, management pun, just now I already told you, just go along the flow. Okay, and then tanya aja, thoroughly ask the question, and then jangan lupa. Okay, patient had thyroid disease in pregnancy, and then in final protocol, I was just waiting for this cord blood thyroid function test. Itu pun yang candidate ni tak jawab. Okay, so at least do some cord blood DFT. So what is the reason why we want to do the cord blood DFT? So I have already write down the reason. Okay, so kena jawab if the patient mother has hypothyroidism ke ataupun hypothyroidism after delivery. Okay, third stage of labor after delivery of the fetus. Okay, you need to take the cord blood or thyroid function test. Okay, and then kalau yang lain tak tahu how to jawab pun, you just say regular follow-up with the pediatrician. So pediatric endocrinologist will take care. Okay, itu je. Any question? Sorry lah, I have already taken the 15 minutes. But it's just a short time and I need to cover several topics. Sorry, tadi question ke?
Yes, I have a question. Regarding hematinics, we ask the patient to eat it every day or the dosage or every other day?
Every other day is better. Previously, when I was a medical student, we prescribed the patient every day, daily dosage. Okay, tapi when the researcher they do the research, they find that if you prescribe every other day, the absorption is better, especially for the oral supplement. Okay, the absorption will be better if you give EOD every other day. But the problem with oral medication kan, oh hari ni dah makan ke, belum makan lagi ke, woman tu macam sibuk lagi kan, so they might forget lah. That's one problem. Kalau every day they just set the alarm and then they will just take it. Any more questions? If you have question, you can just personally message me. No, we end the session with recitation of the